We're at the IAS meeting in Vancouver, BC. We're here with Jens Lundgren from the University of Copenhagen, Denmark, and you gave, I guess, several presentations, and there were others that were given, talking about when to start. But the START study reveals some data still, and I'd like you to introduce some of that to us here.
Sure. There's been a controversy of when we should start antiviral treatment in the course of chronic HIV disease. The concern has been that there was some harm from using these drugs, in particular people at a high CD4 cell count. And we thought it was very important to settle that controversy by doing a large clinical randomized trial, 4,685 participants. Half of them started early, the rest deferred their treatment until lower CD4 cell counts. And the result was recently unblinded to us, and we are reporting them here at the IAS and in a paper in the New England Journal of Medicine. And what the data show is very convincingly and definitively that there is a issue in terms of untreated HIV, in terms of immune deficiency, that is also apparent at very high CD4 cell count, which antiviral treatment is at least partially repairing. So this and the types of diseases that develops are cancers.
And you wouldn't even really think about that, but
but that's interesting because I mean our concept about HIV and what you get sick from HIV is mostly defined in people with low CD4 cell count.
An opportunistic infection.
Exactly, but these diseases actually happens also at high CD4 cell count, obviously at lower rate compared to at lower CD4 cell count, but they do develop. And what the study clearly shows is that if you put people on antiviral treatment, that those holes in the immune system that allows these diseases to develop are at least partially and substantially and durably filled. So therefore people don't get those diseases. So the data really shows that we should recommend everybody who's HIV positive be on treatment.
And we stopped the study because
we don't stop it, but we unblind it and communicate the results we have so far because we think this is we could not ethically continue the study because the data was so convincing. So there is some ethics here that we need to make sure we comply with, but also that it's important that a controversy that have to some extent sort of split the expert field. Some were sort of very interested in getting everybody in treatment, others were more concerned that the individual benefit as opposed to the harm from early treatment, how was that weighing itself up? But now we have the data to show that, and I think that sort of unifies the field in that we can now all talk and send out the message that you really need to get tested and seek care as soon as you are HIV positive, and you should start on treatment. At least that would be the recommendation. There may be individual choices that makes some people reluctant not to do that, and that's something that they need to talk with.
You don't want to you don't want to push somebody into a treatment that they're really not ready for,
exactly.
or will even complete the take.
No. I mean the actual individual decision is a decision that is made between the patient and his and her physician. The word recommendation means that there
guidelines,
and also that there's a strategy now that is clear. But whether people want to follow that strategy, that is of course up to them to decide. Now they have the data to quantify the potential risk that they are having by not starting on treatment, and the benefits that they would have if they started on treatment. And I think that would therefore inform that individual choice, and that was why we did the study.
Are most of the events, do you think, precipitated by, or at least in part by, inflammation?
Actually not. No. It was quite surprising. I know that has been the dogma for many years, that if you treat HIV, you reduce inflammation. And it does. There is a reduction in inflammation. But the type of diseases you would expect in that situation would more be cardiovascular disease, most typically. We did see some cardiovascular disease, but there was no apparent difference in those who had started on treatment as opposed to those who had not, which was a surprise.
Yeah.
So again, the diseases that was driving the benefit from early treatment was not associated with inflammation per se, but were cancer events and some opportunistic diseases. The study was done worldwide. We had 20% of the participants from Africa. They obviously had TB, but if they were started on treatment, there was substantial reduction in the risk of TB.
But that would become, because they were more virally competent, they were more immune competent.
Exactly, but we have always talked about the CD4 cell count capturing the immune deficiency in HIV. But these people that was enrolled in START, they lived with a very high CD4 cell count, a CD4 cell count level which if you go out and measure CD4 cell count in the general population, would be characterizing as a normal CD4 cell count. So I think the data also points out the fact that although we have been relying on the CD4 cell count to really identify those who had an impaired immune system, as a matter of fact, the data we are now showing shows that you have an impaired immune system also when the CD4 cell count is high, and therefore we really need to now focus our research effort to try to understand, are there other markers other than CD4 cell count that can actually identify that immune impairment issue, because the CD4 cell count is not picking it up.
So we don't have the markers we need.
No.
And so it looks like even the elite controllers or virologic controllers would also be. But you didn't evaluate them.
We did evaluate them.
Okay,
we included around 400 participants out of the 4,600 who had at entry a low viral load. It's not a sufficiently large cohort to make conclusive statements specifically on that small subgroup. But by the looks of it, they would also have benefit from early treatment.
Great. Well, so the message here is for those who are not being tested, be tested.
Yeah, absolutely.
And for those that are being tested and find out they're positive, or I should say be retested, but if they find out they're positive, get on treatment. It seems
get yourself linked to a care.
The data is there.
The data is there.
Out.
Yeah. So I mean that, and I think that's really the message coming out of the Vancouver meeting. Get tested, and if you're positive, seek care. Be retained in care.
And take your drugs, your treatments religiously, or completely all the time, because it is so critical for you to go to undetectable, and therefore be less of a risk for transmitting the virus to others. And we, to get to that and to segue, we talked about this earlier, about the relative risk. People who are undetectable are really, really, really low risk.
Yeah, I mean the HPTN 052 data they have an update shown on this conference where they had 3 transmissions in people who were on treatment.
But those were explained.
Those were all explained. I mean, we're doing a large study, the partner study, where we are actually studying a much larger cohort of patients, and so far we have found no link transmissions.
And how many events were in that, sexual encounters or events?
Oh, we're now up to, if you count the number of intercourses, we're up to 70,000 intercourses.
I think I remember last time I heard, I guess it was at the Croix, maybe 40,000.
Yeah. But it's, people still have sex, so
right.
We accumulate.
Which is good. I mean, it's healthy. It's healthy.
So in partner study, the one thing that we are still not 100% sort of finished with is anal sex. There is, which is why we are continuing.
That's the most risk.
That's the one, at least untreated, where the risk of transmission is the highest. So we just, since we have the study ongoing now, we are now continuously enrolling MSM couples, just to make sure that we get sort of the definitive data on that as well. But the data so far looks good.
Well, I really appreciate your helping with the reality of this as it is presented at a meeting of science, not of dogma or suspicion or whatever. But people need to really understand the real risks that are out there and not just create them just because they feel this is what it is. It's only what it is when it's done in a scientific way, and that's what we really appreciate you're doing, and the others in the field are doing such good work.
Yeah, thank you very much. Appreciate it.
Thank you very much.
Thank you. Appreciate it.